So back to today's event, and if there are no other announcements, as I said, our rounds today is sponsored by the Clinical Translation Corps, run by Michael Yin and Susan Tross, who are both here. And it's called Pharmacological Biomarkers for Assessment of HIV Prevention and Treatment, Methods and Uses. I'm going to introduce all three panelists and then simply turn it over to them. We'll have our usual format where they will all present, and then we'll have time for Q&A and discussion at the end. So I'll be brief with each of these introductions. So first up will be Dr. Michael Yin, who, as I said, is a co-director with Susan Tross of this Clinical Translation Corps of the current center. He's a professor of medicine in the Division of Infectious Diseases here at CUIMC and director of the Program for Education in Global and Population Health at the Vagelos College of Physicians and Surgeons and co-director of the Corps. He received his MD and MS in epidemiology and completed residency in infectious disease training here at Columbia University. And his longstanding research focus has been on non-infectious complications of HIV, broadly recognized for expertise in musculoskeletal complications. He has worked extensively with the ACTG and the Max Wise cohorts, and collaborated with clinicians, laboratory implementation scientists at CUMC on a variety of studies to optimize HIV treatment and prevention. And then we have Dr. Kathrine Meyers with us, who is an associate professor of biobehavioral sciences here at the Aaron Diamond Center in the Division of Infectious Disease and Department of Medicine at Columbia. She's a social scientist committed to advancing health equity by accelerating, I just lost my place, access to proven therapeutic preventive and diagnostic interventions by marginalized and vulnerable populations. Her research focuses on designing and delivering community-centered interventions that account for the psychosocial, sociocultural, institutional factors shaping access to effective care in real-world settings. And I've had the pleasure, of course, of working with Kathrine as well as Mike, and the implementation science work is really great. It's characterized by stakeholder engagement throughout the project life cycle from design to dissemination. And then last but not least, and I'm personally really pleased to see Dr. Serge Cremers, who I had the good fortune of working with many years ago. We can't remember exactly how many years ago, but we worked together on various projects where he ran assays and laboratory things for us projects that I've led and co-led with other investigators in the HIV Center. Dr. Cremers received his PharmD from the University of Groningen in 1996 and his PhD from Leiden University in the Netherlands. So he's from the Netherlands originally. He joined Columbia University in 2006 after working for 2 years as a clinical pharmacologist at Novartis Oncology in New Jersey. He is currently professor of pathology and cell biology and medicine at CUMC. He is co-director of the Pathology's Clinical Pharmacological and Toxicology Laboratory, as well as co-director of the Translation Therapeutic Accelerator of the Irving Institute for Clinical and Translation Research. Dr. Cremers' research focuses on clinical and translational pharmacology of drugs in psychiatry, cancer, transplantation, contraception, and metabolic bone diseases. So you can see the connection amongst all three of these presenters. Serge is also the editor-in-chief of the British Journal of Clinical Pharmacology. They all do great translational implementation work, thus present sponsorship of our Clinical Translation Corps. And I'm now going to turn it over to you, Michael. Give a warm welcome to our panel.
Thanks for that kind introduction. So I'm going to kick it off. We have two objectives. The first is to review the characteristics of pharmacologic biomarkers to monitor tenofovir adherence. And the second is to discuss the tail prep study, which is a use case for cabotegravir levels. in decision making about how long to take oral PrEP after discontinuation of cabotegravir. So by background, we know that adherence to antiretrovirals for both prevention and treatment is important, but self-report adherence is quite inaccurate. There's recall bias and bias from social desirability. Objective measures of adherence for research and clinical care range from things like pill dispenser tracking with the WISE pill, or pharmacologic metrics, which measure antiretroviral levels. And these can come in different flavors. So you can measure levels in the plasma, in the cells, the peripheral blood mononuclear cells, dried blood spot, which uses capillary blood. You can measure levels in hair and urine and saliva. For HIV therapy, we have a biologic measure where we can look at the HIV viral load. And that's a great indicator of adherence to antiretrovirals, but that doesn't exist for prevention. So just a reminder about the characteristics of tenofovir, which is the drug that is most commonly measured for both treatment and prevention. Tenofovir disoproxil fumarate, TDF, is one that has high plasma concentrations of tenofovir. TFV is the abbreviation for tenofovir. So it has most of its measurable levels are in the plasma. It has much lower levels in the cell, pictured on the right in the lymphoid cells. On the other hand, tenofovir alafenamide fumarate, which is the newer formulation, has much lower levels in the plasma and has higher concentration in the cells. And in the cells, it's converted by 2-phosphorylation steps into tenofovir disoproxil fumarate. So 2 phosphates, and that will remain in the cell. And that's what is measured when you're talking about intracellular concentrations. So how do we measure these levels of antiretrovirals? You use liquid chromatography and tandem mass spectrometry. Serge Cremers is going to go over this in greater detail later on. It gives a quantitative measure, so you can have a large range of levels. And as mentioned before, you kind of measure different analytes in plasma versus hair and cells. There are other characteristics too. So when you look at plasma and peripheral blood mononuclear cell levels, you need a phlebotomy, so you need to have blood drawn. Dried blood spot is interesting. You can use either blood that's drawn from the vein, or you can do a finger prick and get capillary blood, and you can put it on to a card that you can collect by yourself. It has ambient stability, meaning that it can dry in air and be stable. And when it's refrigerated, it can be stable for up to a year. So it's easy for shipping, very easy for research purposes, simpler sample processing. Hair has similar characteristics in that way, that it has simple transport, but it's a little bit more difficult to obtain. You have to cut strands of hair close to the scalp, a pretty big number of strands. And then there are less labs that can do this. And what a very interesting characteristics of this is that you can do segmental analysis. So you can look at patterns of adherence over time by looking at which segment of hair. On the other hand, there is a urine assay, which has a different property. It's an immunoassay, so it's measuring antibodies to tenofovir. It doesn't have the same range in terms of what values it can give you, so it's qualified as semi-quantitative. This is just a figure that displays some of the characteristics we talked about. If you want to assess recent adherence, the measures that you would use are in plasma and urine. If you want to look at cumulative adherence in terms of weeks to months, then your choices are to look at it in terms of the levels in cells, or in dried blood spots, or in hair. So probably the most commonly used in research has been the dried blood spot. I think a lot of it has to do with the simplicity and the availability of sort of the collection simplicity of the dried blood spots. There are very nice measures to correlate adherence with the levels that you're measuring in the dried blood spots, which also is very valuable both in clinical care and in research. Bob and the rest of the group has done great work in terms of the ADART in treatment studies. I'm going to give you a couple of examples of using dried blood spots for adherence feedback in prevention studies that have been published, which I think are really interesting. So rather than just using it to determine what the adherence has been over time, the idea is, could you use the dried blood spot levels as feedback for participants to improve adherence? So HPTN 082 looked at women in South Africa and Zimbabwe who started PrEP. They were randomized to a standard adherence support or enhanced support with feedback from the dried blood spots. And they showed that the drug feedback levels in the first 3 months didn't increase the proportion of people who had high adherence at month 6. The PrEP Smart study looked at 360 women in South Africa randomized to once weekly SMS communication or WhatsApp peer support group. So that was the first randomization for 2 different ways of giving support. And then at month 3, the participants with low PrEP adherence were randomized again to an intensified counseling once monthly or dried blood spot drug level feedback counseling at months 3 and 6. So at month 9, there was no difference in adherence by dried blood spots between the group that got the drug level feedback and the monthly counseling arm. So in the discussion, they talked about some of the challenges with the dried blood spots. There's a long laboratory turnaround time and costs. It prevents timely feedback. And so maybe that's a limitation of the use of the dried blood spot technique in terms of improving adherence and using it for adherence feedback. So newer studies have used the urine point of care tenofovir assay. And I think Monica Gandhi spoke about this a couple of years ago here. So this is an immunoassay. It works just like the COVID test, where it's very easy to run and interpret. And if you have 2 lines, it means that you have some level of tenofovir that's measurable. And so you can change the gain of the study. And what they have here is a level of greater than 1,500 nanograms per ml, really indicates high accuracy for daily tenofovir use. So I'm just going to go through these 2 quick studies about using tenofovir urine assays for immediate adherence feedback. And so there's an example in treatment study, which was done in Namibia in people with HIV with viremia who started antiretroviral therapy with a tenofovir regimen. And when they were given this as a way of monitoring their tenofovir adherence, they had a higher level of 3-month suppression with the antiretroviral in comparison to historical controls. In a prevention study, which is a randomized clinical trial of PrEP in 100 women, serodiscordant partnerships in Kenya, they randomized into an intervention with counseling informed by tenofovir urine level testing every 3 months versus standard of care without the testing, but they stored the urine so that they could look at the levels later on in analysis. And in the figure to the right, it shows that the group that got the tenofovir informed adherence counseling, which is in red, they had higher levels of tenofovir by the urine assay throughout the study. And the last one, looking at this, was recently published in 2025. This is by the UCSF group, and they looked at a randomized clinical trial of 63 MSM on daily oral PrEP. And in this case, they had self-collection with both urine and hair, and they were randomized to intervention with motivational interviewing informed adherence counseling with a psychologist over Zoom. And so the participant would administer their own point of care tenofovir urine test, and the counselor would provide feedback based upon those findings. And in the standard of care, they didn't have that. And what they showed is that the hair tenofovir levels were higher in the group that received the urine point of care testing as compared to the standard of care group. And that level of increase shown in the figure to the right corresponded with an additional 1 to 2 tablets of tenofovir per week. So this is quite interesting and encouraging that potentially the point of care immediate feedback with the drug levels could be helpful in improving adherence. So that's where I'll end with the story about adherence testing in the realm of oral HIV medications for treatment and prevention. The issue that we want to talk about next is what do you do now that most of the prevention modalities are going to be long-acting injectables and some of the treatment modalities as well. And so I'll turn it over to Kathrine.
All right. So as Mike noted, we're going to turn and think about long-acting PrEP, and specifically to think about intervention we're trying to develop for the safe discontinuation of long-acting injectable cabotegravir specifically. So long-acting CAB, which I'll call CAB-LA, offers an opportunity to increase PrEP uptake, but has a long and variable half-life. And in some individuals, CAB levels have been quantifiable for over 12 months after the last injection. And there's a lot of interperson variability. And people say that it's related to sex and BMI, but the studies show that actually sex at birth and BMI only account for 10% of the variability. So 90% of the variability is sort of unknown or uncharacterized. So this variable tail period, which starts 8 weeks after the last injection, means that there is this zone of resistance risk. This is what the CDC calls it. So in the figure on the right, that area circled in red is a period where you have cabotegravir levels that are less than what is protective against HIV, but it's still on board. And so if during that time you came into contact with HIV, there is a theoretical risk of resistance developing. So this is sort of the period that we are targeting in the intervention we're developing. So the CDC recommends that for people who are discontinuing CAB-LA, they should be switched to oral PrEP for as long as they are at risk for HIV, but they don't provide a time frame for how long that should be. This approach has implementation challenges because people on CAB-LA or who choose to take CAB-LA often want to avoid a daily oral pill. That's why they chose the injectable. And so now saying, well, after you stop taking the injectable, please take an oral pill for 12 months isn't really consonant with their preferences and needs. The other point that's important is that everybody who starts CAB-LA is at some point going to discontinue CAB-LA. So it is going to affect anybody who initiates unless they are unfortunate to seroconvert, and then they might be put on a treatment regimen. The other thing that we hear a lot is that people stop CAB-LA or stop PrEP because they feel that they are no longer at risk of acquiring HIV. So they have a low self-perception of HIV risk, which makes it particularly hard to then say, well, you should keep taking oral PrEP during this time. And then when we started this study, providers were hesitant to prescribe CAB-LA because they were really, they understood this most intimately and were worried about, well, if we start people on CAB-LA and then we tell them, okay, switch to oral PrEP, no one's going to do this. And we're going to now have all these people who are at risk for breeding resistance. So to capture these implementation challenges, we wrote, many of us here in the room actually collaborated to write this commentary that was published in 2023, which was also the time where we were awarded the tail PrEP R21. I will just note here, and I'll come back to us, that the 6-month lenacapavir injections have, I'm supposed to say, changed everything with its approval in June 2025. And I'll return to that. So the tail PrEP intervention has 2 components: monthly CAB-LA drug level monitoring with specimens that are self-collected at home, which I'll describe in a moment, and then monthly personalized goal setting with providers, in this case, counselor, for oral PrEP adherence or other HIV prevention methods during that period of risk based on their clearing of CAB-LA drug levels. So this grant was developed with a multidisciplinary team. It included the NYP HIV prevention program led by Dr. Zucker and Carrie Carnevale. The Department of Health collaborated with us and gave us access to the HIV planning group for their feedback. And then clinical, social, and laboratory scientists here at Columbia. It was funded by an R21, which was unfortunately caught up in all the turmoil at Columbia and was terminated in March 2025, the week that we were about to launch the intervention. And then it was reinstated in 2025, but without any direction as to whether we would get a no-cost extension. And so we then waited for several months to know whether we would have a full extra year. So aim one was of the study was to validate an assay to detect CAB levels in blood specimens and compare samples collected by different methods and assess their acceptability and feasibility to patients. So Mike spoke about the dry blood spot. I think many of you in the room and online will be familiar with this method. You do a finger prick and then you put it on the filter paper. The other version of collecting drug that we were interested in investigating was with a Tasso device, which I have here and you can pass around. It's shown here in the bottom pictures. You basically attach it to your arm, depress, and then a small amount of blood is collected. And we wanted to understand the acceptability and feasibility of both of those methods compared to venous blood draws in the clinic. Aim two is then to evaluate acceptability and feasibility of the whole intervention with the self-collected blood and the counseling intervention. And then aim three is to iteratively refine the tail prep intervention based on what we find from our participants. So for aim one, we enrolled folks who were on an injectable CAB containing regimen for either prevention or treatment, or people who had discontinued injectable CAB in the past 12 months. We enrolled them at NYP, at the Comprehensive Health Program at HP6, and in the Sexual Health Program at BC3. And so folks who were enrolled gave us the venous blood sample, dry blood spot sample, and a Tasso sample. And a survey was administered to collect demographics, medical history, and acceptability and feasibility measures. And participants got a $75 gift card, and they were eligible to participate in repeat study visits so that we could see whether their acceptability and feasibility of the sample collection methods changed over time. So here, these are the AIM and the FIM, which are validated scales to measure acceptability and feasibility. On the top, it's the AIM and FIM standardized questions related to the DBS, and on the bottom, it's related to the Tasso device. So here we show the mean scores for acceptability and feasibility on the left. And what you can see in the blue bars is that the BLD, which is the blood lancet device or the Tasso device, had higher mean acceptability, higher mean feasibility, higher openness to repeat sampling. And then we asked them about their comfort relative to venipuncture. And again, the Tasso device outperformed dry blood spot on all those measures. On the right, we then decided this hasn't been done with the AIM-FIM, but we thought it's important to have like a threshold of acceptability. So on a 5-point scale, we said if it's 4 or 5, we think that means it's acceptable. And so you see in the darker area.
Standing in front of the mass spec, this is why we put in samples. There's some columns there. Sorry, there's some columns on there, and then it pushes into this instrument that he's standing in front of. And what we do in that instrument is we ionize the compounds, but both cabotegravir as well as deuterated cabotegravir, in this case in a positive mode. So we add a proton. Then within the mass spec, so this is not one MS, but it's MS or tandem mass spectrometry. So now you know what those terminologies are, or quadruples is what we also use. We break down the product with, I think, argon, and then we get a daughter ion. So we have ion and a daughter ion. We measure both of those transitions. And we do that both for a quantifier and a qualifier for both the compound itself and an internal standards with all these settings. Now, why am I showing you this? Because you say, well, who cares? Well, it's all because just to illustrate you that we put a lot of effort into this to bring down the background and to get end up with very specific and sensitive assays. And so we need to do that. Every instrument is different. So our instruments are different from the ones in Johns Hopkins. So it's not like we could, very easily copy paste what Mark Mazinski told us, although it was very useful what he did say. So now I'm going to switch to the next one. What you're then going to end up with, is these kind of chromatograms, and also they're a little small, so I'll have a bigger version on the next version, and calibration lines. So each time when we run a sample, we have these when we do a run, we have these calibrators these nice calibration lines that we use to calculate what the concentrations in the unknown samples are. So moving on. So here you see chromatograms of 4 different samples, and what you see in the first 2 chromatograms are the upper 2 from, let's say, A, and this is the signal. The one below that is the signal of the internal standard. And from A is a blank, B is our lowest calibrator, so that's about 10 nanograms per ml, and then you should try to remember that 10 nanograms per ml, but it's a pretty decent peak, and we can probably go very much lower. Then on C, we are at a sample of about 200 nanograms per ml collected with a Tasso device, and then on D, we did. It's a patient that I think Mike sent us with capnography of about, about 1,400 nanograms per ml collected in a venous blood collection tube. So we have an assay that seems to be working, but you can validate it to some extent. But before you can actually use it for patient care, we have to go through a whole textbook of that New York State that tells us what to do before we can start using it. And then we have to collect that into kind of like a mini FDA dossier, submit it to them. Oh, hi.
We should let it be for right now.
Okay.
And then maybe at the next.
Yeah, no, I'm not used to it. So I'm totally chuckling. So these are some of the requirements that New York State tells us to do. First, and very important, is we need to do a risk assessment. That means that if you mess up with this assay, what are the consequences? Are people dying or not? And they might not always. They might take a second look. Clinical validity, and this is what we'll discuss later. Does it really make sense for patient care to actually measure capnography levels, both from as trough levels and at as peak trough levels, as well as for the tail phase. And then there's things like precision, accuracy, sensitivity, linearity, analytical measurement range, and last but not least, we really make these assays, put them to the test by letting all sorts of interferences and different patient samples in there, because we know that assays can look great on paper if you do everything in clean serum, and then when we go to patients, it's usually one big mess, and we have to figure all those interferences beforehand. And stability is also a big issue. The good thing is, once we have approval from the state, that's when we can apply it for patient care. And we have approval from the state for this particular assay, so which you can now order online from us, or you can send the samples to us, and clinical studies. And it can also be used for clinical studies during which patient management might change. So moving on. So then specifically what we do with the validation of these assays is not just what New York State tells us to, but we also really tailor it to the future use. So one of them is, for instance, looking at the sensitivity and the absolute measurement range. In this case, what we need to do is measure both the higher levels and the very low levels for the tail phase. a cross-validation with Johns Hopkins University because the lab there, because well, most of the data actually comes from them. So in order to be able to use their clinical data, also we need to get the same results. We need to have stability during storage and transport. You can imagine that when Kathrine wants to do the study that the TASO device is collected, the sample is tucked off, it's closed hopefully by the patient, and then it's put in an envelope or in a refrigerator, only to then be sent here to the lab, hopefully later on, whether or not that has to be on dry ice or whether that has to be on cool pack or whether that can just be in an envelope, and how long it takes in order to get here are very big are issues that you need to figure out. And then does the TASO device, plasma from a TASO device, does that get the same results as that in lavender tubes? Because that's also very important, because I think for the most of the Hopkins studies, they just use lavender tube studies, they didn't use TASO device. So this is some of that data. Oh, now I have to also put the other one. These are some of the data from one of the publications from the Johns Hopkins, where you see decreasing concentrations. This is the concentrations in males and females, I think somewhere in Africa, time since the last injections in weeks. And you see as these dotted lines are the protein-adjusted IC90 values. So that means that capnography is very highly protein-bound, and so the real IC90 is much lower. But in order to correct for that, because we're measuring total, and they're also measuring total capnography levels, these protein-adjusted IC90s are much higher. So relative to those, if you see, first of all, you see this huge variability in the levels themselves, both at the early phase, but also at the later phases. And as Kathrine said, we're not quite sure why that is. It has something to do with the UGT metabolism, but probably more importantly, it probably has to do with the release kinetics of the capnography from the muscular compartment. So just for the numbers to remember, at about 12 weeks after, the levels range between 100, 1,000 and 10,000. So that's first of all what we need to do if we want to measure trough levels after 3 months. Patients are being treated every 3 months. The trough level or the tail phase levels, they need to go down to at least 25 nanograms per ml, preferably even lower. So as you will see, we go down to about 10 nanograms per ml. Although we're not quite sure that if you find in somebody, and this is something for the discussion, if you find capnography at 10 nanogram per ml in a patient, is that good? Can the patient stop with the oral treatment or PrEP, or is the risk to develop resistance at 10 nanogram per ml, is that 0 to none? So that's something up for the microbiologist and Mike to tell us. I'm going to put you on the spot, Mike. So this is the sensitivity for the assays that we did, ranging from 10 nanogram per ml to 10,000 nanogram per ml. Looks so good. Accuracy looks good over that accuracy range from 10 to 10,000. So this is good. So the assay can be used both for trough level monitoring, so monitor the levels 3 months after an injection and see what those are, as well as for the tail phase. They can be used. The second part is comparison with the clinical pharmacology analytical lab at Johns Hopkins. And as you can see here, they are comparison. These are their levels, these are our levels, and this is that in something called the Blend-Alpen plot. And what we see is that they're actually basically the same. We're very happy if we see these kind of comparison with other labs, because usually one of them is a little bit off, but in this case, we're all very good. So we can use their cutoffs, we can use their data. That's excellent. Now the next phase would be the stability during storage and transport. Now, there's a few things. You have the temperature. We've all seen those boxes outside here in Washington Heights that hang outside, Quest boxes that hang outside the doctor's offices in the glaring sun, and it's probably like 300 degrees inside that box. I wouldn't trust that. But what we do in this case, what we did was we looked at the temperature, whether you can keep it at room temperature, whether it will survive, let's say, one day at 40 degrees Celsius, because that's usually what happens during transport. But the same thing, patients don't immediately centrifuge. Nobody has a centrifuge at home. So a patient sample collected with a Tesla device is not being centrifuged immediately. It is centrifuged by the time it actually reaches the lab here. So we have to figure out whether over that time, the plasma concentration of cabotegravir doesn't change at all. And so what we found was that it was actually really good. There was whole stability of the there's good stability over temperature and centrifuge, whether you immediately centrifuge or centrifuge a couple of days later, it doesn't really matter. So that's good news, as long as there's not too much hemolysis, because then there's a few other issues that come into place. But so we can do this study with a Tesla device, and I think you can shove it in an envelope and then they can send it, or with a quote back with maybe just in case. Then the third thing, do the lavender tubes get the same result as Tesla? Yes. So in this case, you see the lavender tubes, and these are the Tesla Plus devices. And we basically, again, got exactly the same results. So we did this study. Here, you guys collected both from patients with a Tesla device and with the lavender tube. And we then analyzed them, and they look great. They give the same results. So you're already set and ready to go. And we got approval from the state. So that's another thing. So it's good for the study. And of course, we're the only lab in the US that does cabotegravir in plasma for patient care. All the other labs are either only research or only research. And reasons why Quest or LabCorp doesn't do this is because the expected volume is very low. You're not going to make hundreds and hundreds of thousands of dollars with this particular assay. So you can only get labs that are willing to run something at a deficit and somehow know how to circumvent that chair or that. So don't tell Kevin Gardner that this might not be the moneymaker I promised it to be. But they can be used for patient. In this case, we do this. And this is not the only type of assay that we have as such. So we get a lot of these assays that we're really the only one, either in the US or around the world. We get samples shipped from all over. And that ranges from 1 to 5 a week or something, or 1 to 5 a month. In this case, we will go run the cabotegravir weekly. So that would be the turnaround time for this stand. They can samples for patient care. So let's say, Mike, if you have patients, you can send them to the lab, either collected by lavender tubes, or they could use the Tesla device. And then how to do that, we're actually using, if patients are outside of the MYP and Columbia system, they can use AIUP, one of the reference labs, to actually send the samples there, and they will send it to us, and then we can measure it in that. They will also we're sending the invoice to ARUP, they will pay us, and then ARUP will come after the patients or the doctor's offices or institutions to look at that. So all things relevant on the background that are unfortunately also relevant. But yeah, and if you have something either for studies or for this, then please come. And that's, I think, all I have. And then I think Kathrine is taking over again. Good luck. It's easier if you do it like this.
Okay.
Keep going.
So
Let's try.
this going
Yeah.
down, and then press that one.
Okay.
And this
Okay.
one does that.
Okay.
This one is there.
All right.
It takes 3 slides to get used.
Okay.
Yeah, okay.
I think we should just go. So, so we have an assay, which is great for the idea of the intervention we want to develop. And we wanted to use this assay by having people who are discontinuing cabotegravir collect the blood at home with the Tasso device that they get sent, have them send it back to the lab and have it run, and then have the levels communicated to a counselor whom we have hired to deliver monthly personalized adherence counseling for what their behavior should be with regard to covering that tail. So this is where I'm going to tell you a little bit about how we developed the counseling intervention. So this is where we started. Blueprint is another project that I co-led with Sarit Golub at Hunter. And this is what we created, and I should say Sarit and her team created to explain this sort of zone of resistance. And we started showing this to patients. And it turns out that they didn't understand it or really get much out of it. So at the same time, we were doing some formative work in my group that Ben Lane led, interviewing PrEP users about what it was like to be on PrEP, what it was like to make decisions about whether to continue on oral PrEP, whether to change to a different regimen. And we use this consumer journey framework to map their answers onto this visual. So what you see here is that people start in pre-contemplation, they consider and they gather information about the different forms of PrEP or PrEP in general. And they decide it's not right for me and they go back to pre-contemplation, or they say it's right for me and they continue. And here is what we call the moment of adoption. And it's where they decide they want to try one of the PrEP modalities. As in every human experience, after you make a decision, you experience something, then you evaluate how that experience went. Did I like it? Did I not like it? Do I want to continue this? And if you decide that it's working for you, whether it's oral PrEP or injectable PrEP, you have a loyalty loop, right? You keep going back for the next injection, for the next prescription. Or you might decide, actually, this is not right for me, and you change. And what could change? You could switch regimens. Well, I had oral, I didn't really like it, I'm going to try injectable. Turns out I didn't like that. Now I'm going to go back to oral or stop. You could have a temporary pause with an intention to return in the future, or you could just opt out of PrEP and say biomedical HIV prevention is not for me. So we were doing this research at the same time. And we also conducted stakeholder meetings and interviews with our co-investigators on the study, with Dr. Zucker, Carrie Carnevale, and Mike. And we met with psychologist co-investigators, Bob and Brian Kuttner. And then we hired a health communications consultant, Anton Castellanos Uzigli, and he conducted interviews with client end users and provider end users, where he showed the previous, this image, and then sort of got detailed feedback on how they responded to it. And then we created this MI-informed counseling intervention, and it had 3 components. First, we created an infographic. This exists in English and in Spanish, about your HIV prevention plan after stopping injectable PrEP. And I have to say, there was this key moment when we had a meeting with Bob and Brian, where we realized, like, actually, what's important is not whether you go on to oral PrEP. What's important is what is your HIV prevention plan? And if your risk has really reduced and you think that you're not you're either in a monogamous relationship with someone who's virally suppressed, or you're not having sex. Like, it doesn't mean that you have to take oral PrEP. There could be other options. And so we created this, instead of saying like, what do you do to cover the tail with biomedical prevention, we just said, what's your prevention plan after stopping? And then we made these 2 videos, both in English and in Spanish. One is about HIV prevention and choice in general, and then one is more specific about stopping injectable PrEP. And then finally, we created this worksheet that was an interactive worksheet that the counselor could use with the person who was enrolled in the study to talk about, their testing behavior, where they're going for their medical care, their communication with partners, and all of that information would then inform a counseling intervention, and shared decision-making around what you should do now. The drug level monitoring is then integrated into those counseling sessions. And so we enrolled our first patient yesterday, I'm happy to say, and we are, yes, it really deserves applause for Nadia, and then our team, Charlie, and then we have 2 undergrad Columbia RAs who are fantastic, Frankie and Caden. And they've been waiting for this moment. So they enrolled their first person yesterday, and we're looking for people. We have sort of 5 partners with whom we're recruiting. They're all high volume cabotegravir prescribers, but it's very, very slow because many of the people who stopped cabotegravir switched to lenacapavir. And so this has complicated the study. But we are now expanding to any high volume cabotegravir prescribers across the country who would like to enroll in the study. So the study includes a baseline survey where we understand who they are, what their behaviors are, the monthly self-collection of the blood, and then these counseling visits with the counselor that Brian trained to use sort of MI to help them make their decision about how to stay protected from HIV. And then there'll be a monthly survey to assess their past month behavior and the acceptability and feasibility. It's a quarterly survey to assess their behavior and then acceptability and feasibility of the intervention components, including the counseling and the drug level monitoring. And importantly, we made the gift card. We were very clear that the gift card is for their participation in the study procedure, so the survey, but not for the counseling intervention. So do they show up for the counseling intervention with our counselor is part of feasibility or acceptability, right? If they don't find it useful, they're not going to show up to those virtual sessions. And we're not compensating them for those virtual sessions. So that is where we are with the tail prep study. I wanted to also just briefly, for the tail prep study, it is a pilot, it's an R21. We're looking for 30 participants. So it's not a lot of people. As I said, it is not that easy to find people who have not switched to Len. So if anyone has connections to clinics or and wants to send people our way, please contact us, and we have recruitment materials to share. We also realize that we have this unique opportunity to also talk to folks who have tried Len. And potentially what we're hearing, there are a lot of people who try Len and then actually don't like it, and they may be going back to cabotegravir, or they may be deciding to discontinue. So we also have written sort of a sub-aim that allows us to interview Len users to understand their decision-making as well. The nodules. The nodules is what most people are not enjoying. Although I've heard that the arm, I don't know what this is called. There's a new location for the injections should be approved in the next 6 months, and I think people think it will be much more acceptable when it's in the arm.
Thanks.
Yeah.
People who just continue CAB, who did switch to lead, actually are still eligible for the study. It may be that it may be salient for them because they're not concerned about the tail because of the but they can still join the study.
Right. Yes. Thank you. So I'll just close by saying we are also thinking about other uses for the cabotegravir assay, we're thinking of it in the treatment space. So patients who start CAB-containing regimens for HIV treatment and are at a higher risk for treatment failure, we might consider monitoring their cabotegravir levels. We are hearing that there are some patients who have persistent low-level viremia, and there's some interest in understanding whether that has something to do with the amount of drug that they have and how they are metabolizing that, or whether it's totally unrelated. So we're interested in starting studies to look at that as well. And then the last thing that we've heard is that people who have been taking a pill every day, whether for prevention or for treatment, there's something that it taps into their own control and self-efficacy about taking that pill every day. And when they stop that because they're moving to an injection, there's this nervousness of is it going to work? How do I know it's going to work in my body? And we've heard that in interviews. And so we are wondering whether we could use the drug level monitoring as a way to assuage their their anxiety in that initial period before the viral load comes down in the treatment context. So those are other potential use cases that we are interested in exploring, and we're super open to collaborating if anyone has a use that they can imagine for this assay. And that's it. Thank you.
Thank you all three of